schedule online, anytime. Now you can easily schedule an appointment with Ascension Care Teams at Seton. Find your appointment online, anytime at getseatoncare.com.
Public dialogue and civic engagement are important. They play a role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is proud to support Texas Tribune events like the conversation you're about to see.
Hello, everyone. My name is Marissa Evans. I'm the Health and Human Services Policy Reporter with the Texas Tribune here in Austin. And we are so excited to welcome you to our 8th annual Trib Festival and to our panel, Dangerous Deliveries, our panel on maternal mortality and morbidity in Texas. So thank you so much for being here. We really appreciate it. Before we get started, I have to do some reading. This panel is presented by Ascension Seton and the Annie E. Casey Foundation and supported by Blue Cross and Blue Shield of Texas. Though corporate sponsors and donors underwrite this event, they play no role in determining the panel's content, panelists, or line of questioning. I am very thrilled to have a small but esteemed set of panelists. To my left, I have Sable Moya, a mother and survivor of postpartum preeclampsia, a condition characterized by high blood pressure after giving birth. In March 2014, she survived a stroke soon after giving birth to her newborn son. And if you read Dangerous Deliveries, she was one of the mothers we interviewed for our very first big piece. So we're really excited she's here and joining us from McAllen. Next to her, Dr. Carla Ortique, Vice Chairwoman of the Texas Maternal Mortality and Morbidity Task Force, which was founded in 2013. She has been a practicing OBGYN since 1997 and currently practices at Texas Children's Hospital. And last but not least, Representative Shawn Thierry, a Democrat from Houston who has represented House District 146 in the legislature since 2017. She is a member of the House County Affairs and Juvenile Justice and Family Issues Committees. She sponsored several bills during the 2017 legislative sessions focusing on maternal mortality. So welcome to our panelists. So this event will last 60 minutes and will include about 15 to 20 minutes of Q&A. There will be microphones somewhere in the audience, I'm sure. And just a reminder to silence your phones. And for those who want to tweet, the hashtag is TribFest18. So I will get right into it. We've been talking about maternal mortality for, I would argue, about 2 years now, right? Since that first report came out in 2016. And so from then to today, how would you say the conversation on maternal mortality has changed, for better or for worse? Sable?
I don't know. I have no idea, honestly. I mean, it's definitely, ever since this article came out, a lot more people are finding out about it, which is great because, you know, I wouldn't be here if it wasn't for a lot of stuff. But yeah, I think it has definitely gained some attention. Yeah, absolutely.
Well, I think that the media has certainly paid a lot more attention, and the more media attention on any problem, the more action takes place. So there's been a lot of emphasis on addressing the problem and identifying changes.
I think it's been huge. I think it was a real kind of a blockbuster. It started kind of a very slow surge, and I like to say that Texas was the game changer. We look at it on a national level now, and there is talk in Congress about it. I think Senator Kamala Harris has already filed a bill to address this issue, mirroring a lot of the issues that we were talking about last session right here in Texas. Magazines all across the country and internationally are following the work that we did this last session. So I think that, and that was part of it. We knew it was going to be a marathon, not a sprint. But the more that people are aware that this is an epidemic and an endemic, specifically for certain racial groups. I think that, that helps because people are aware now and actions are being taken.
Great. So for you, Representative, how do you see this national conversation playing out in your district right now in real time?
Yeah, really, I always say, you know, even though this is a topic that tends to be kind of heavy and people don't like to speak about it as much, I do have some good news to share. Houston-Harris County has hit the ground running on this. There's a couple different programs that I'm a part of and where we've already implemented steps to reduce maternal morbidity. We have a Houston Endowment, which is a nonprofit, help fund a steering committee specifically designed to reduce maternal morbidity and mortality. And there's another community-based group of several stakeholders, over 40 different stakeholders, called Impact. And from the moment that the report came out from the task force, they immediately organized and secured their own funding. You know, they didn't have a lot of help, but they have done a lot of research, we've developed our own findings, our own recommendations in conjunction with what the task force has done. And right now, providers in Houston-Harris County are already getting training on implicit bias. They are working to implement the bundles recommended by ACOG, which is the American College of Obstetrics and Gynecology. They are implementing care managed programs for federally qualified healthcare clinics. So right now, women in Houston will have an opportunity now when they're pregnant and they go to one of these FQHCs, they're assigned care managers now. And they are going to walk them through 3 months, 6 months, 9 months, 12 months, helping them with postpartum, doing risk assessments right then and there when they come in. And so this was all of what we wanted to happen. It's going to take a lot more. They need additional funding and help, and we would obviously like to see this program span throughout the city and Texas. Right now, we're only doing it in certain high-risk communities. Ironically, they're in my district. 3 of the zip codes, unfortunately, with the highest rate of maternal mortality and morbidity are in my district, lower income, underserved communities. So this is what we're doing right now, and we're hoping with these pilot programs that we're implementing, more will be done.
We recently had the state's maternal mortality and maternal morbidity task force report come out that focused on 89 maternal deaths that occurred in 2012, and it found that 4 out of 5 of those pregnancies could have been prevented. It also found that Black women were 50% more likely to suffer a pregnancy-related death than women as a whole, and more than twice as likely to die from pregnancy-related causes than white women. Dr. Ortique, when you were doing that report, can you kind of just walk us through what went into the report and where do we go from here in terms of recommendations in that same report?
Absolutely, and I will just backtrack a little bit. We're saying that we've been talking about this for 2 years, but in reality, maternal mortality has been, obviously, it has been a problem in this country for a long time. It was back in 2006, actually, that in our country, the maternal mortality rate was only about 8 per 100,000. And a statement was made by a then FIGO president that pertained to other countries. And what he said was that pregnancy-related deaths were occurring not because the diseases weren't preventable, but because society did not care enough about the women's lives. And he was referencing other countries. And now, in 2018, our US maternal mortality rate is more than doubled what it was in 2006. And so it's not a problem that just happened in the last 2 years. It's a problem that has gotten attention in the last 2 years. And we really have to focus on that this is something that has been in existence, and now we're paying attention to it. So your question about what went into the report, basically, 2012 was identified as a year where the maternal mortality rate for Texas was reported as 38 per 100,000. That would have made Texas worse than many developing nations, were that number true. So research was done by some members of the task force as well as DSHS, looking at was that number real? How could it have gone from in 2010 around 20 per 100,000 to 38 per 100,000 in 2012? And what they found was that there are a lot of reporting errors. The data quickly, the death certificate is used to get this data. There's a little checkbox that says, was the woman pregnant or was she not? Many, many times. In fact, 60% of the time when they looked at those deaths from 2012, what they found was that the women were not truly pregnant. So they went through and found that the rate was actually only 14 per 100,000 for that year. So from there, we looked at the deaths that actually did occur in 2012. There were 89. We looked at medical records. We look at investigative reports, autopsies, everything to try to find out not just, was she pregnant when she died, but what caused it, what was the cause, and was the cause preventable? And so the important thing from all of this is just that you can't just look at vital statistic data. You will get inaccurate information if you just look at vital statistic data. It is incredibly important that states have review committees or task force to evaluate and determine whether or not a death is preventable. Not all states in this country have review committees. We're thankful to our legislature that in 2011, the task force was legislatively mandated, and then in the most recent session in 2017, the life was extended, and so we're really excited about that as well. But the members of the task force volunteer their time to review, and we are sometimes surprised by some of the findings, like that drug overdose was the #1 cause of death when you looked at deaths that occurred within 1 year of pregnancy. That suicide and homicide were in the top 5 causes. That there is this enormous disparity, that black women are 2 to 3 times more likely to die than white women, even when you control for economic status, education, where you live, disease state like obesity or hypertension. It's often thought that the individual is the one who is driving this, but it's much more than that. It's very multifactorial. It's more than just individually driven.
Thinking about the report, what's the most challenging thing about explaining all of this to legislators? Maybe not representative on here right now, but to other legislators who maybe are still trying to figure out this issue, what do you find is the hardest thing to explain to them about this?
Well, I think that first, there's a lot of medical terminology in there, and it's confusing because one minute a person says pregnancy-related death, and another says pregnancy-associated, and somebody says maternal death, and somebody says 42 days, 365 days, and it all gets jumbled around. When we talk about pregnancy-related versus pregnancy-associated, I've had someone say, well, why do you care about deaths that are not related? So related just means that the pregnancy itself caused or exacerbated a problem that led to the death, as opposed to pregnancy associated, which just means you were pregnant within 365 days of your death. So that could have been a death from a lightning strike, let's say. Well, the thing is, though, if you don't look at what was going on with the woman at that time, maybe the woman who was struck by lightning was outside, under a tree because she was depressed, and that's why she got struck by lightning. So you don't know, that's kind of an extreme example, but the issue is if you just look at the cause, the heart attack or stroke, you don't know for sure whether or not it was truly pregnancy related or not. And then I think the issue of the number. When you say 89 deaths, it's sometimes easy for legislators to say, well, that's a small problem. But the issue is 89 mothers leave behind families, they leave behind communities that are forever impacted by their loss. Number two, if the death is preventable, even one is too many. And we did find that for the pregnancy-related deaths, at least 80% had some potential for prevention. And finally, the cost to society of when someone dies, often they've had a prolonged illness in the hospital. Many of these deaths were to women who were on Medicaid at the time. So we know that Medicaid pays for 50% to 55% of deliveries in our state. So that financial impact is there as well. And then I said finally, but this is really finally, 89 is the tip of the iceberg. For every woman who dies, there are at least 100 who had a near miss, who had an event that they survived. And so we're talking about thousands of women who are experiencing near misses. And that's, I think, one of the, those are the things that I think are difficult to share sometimes.
That makes sense. You know, Sable, we talked on the phone at least about a year ago, which is crazy. And I remember I got off the phone with you thinking, holy crap, I'm not going to say a different word, holy crap, you know, she's a true survivor. But for those who maybe didn't read Dangerous Deliveries yet, which you should, you know, kind of briefly describe to the audience your story and what happened after your pregnancy.
Okay, so I started at a birthing center in Wesco, which is way down in the valley, and I was there for 2 days with, you know, trying to push this child out of my body, and then my water broke at around 5 in the morning, and so after 24 hours you're at risk for infection, and so I got transferred to the hospital, ended up having to have an emergency cesarean section, delivered, and then my blood pressure went up, and we just could not get it down. And my son had jaundice, so I had to go feed him every 2 hours and then come back, you know, with a newly cesarean body, and it was terrible. But so he finally was released from NICU, and then my blood pressure was still really high, and they kept trying to get it down, and then finally they got it down to where it was like barely okay. And so they released me from the hospital around 8 o'clock at night, and then my husband at the time and I drove to the pharmacy down the street. It was a block away from my house, and that's when I had the stroke. And I told my husband, something's not right, we have to go back to the hospital, and then I lost my ability to speak. And so this whole time he thought I was mad at him, and, you know, I wasn't. So he was like, what's wrong? And I couldn't say anything, you know, because I was having a stroke. And so he thought I was just like furious with him. And so, yeah. So he finally gets me back to the hospital, and I couldn't walk anymore. My entire right side was done, you know, it was numb, or I couldn't move it. So he found me a wheelchair. He took me into the ER waiting room, and then it took 2 hours for them to take me to the back. I vomited on myself. I had a seizure. My eyeball, my blood was bleeding. My brain was bleeding so bad that my eyeball was protruding from my skull. And so, yeah, after 2 hours, they finally realized, like, oh, she's having a stroke. And so they took me to the back, and then probably like around midnight, and then had to have emergency bedside surgery. They had to, I still have the indentation in my skull right here. They had to drill a hole in my skull and put a tube in my head so that they could drain all the blood out. And then I was put in medically induced coma for about almost 3 weeks. I couldn't walk, I couldn't talk. I mean, I was I was just in the bed. And so after that, I got transferred up to Houston to TIER, and I was there for about 2 months, and it was Monday through Friday, physical therapy, occupational therapy, speech therapy, every kind of therapy you can imagine, 8 to 5, Monday through Friday. And then after 2 months there, I was transferred to this neuro rehab called Mentis. And that was another 2 months of that. And it was the same thing, you know, Monday through Friday, 8 to 5, every kind of therapy imaginable. But yeah, I mean, I woke up, I thought it was 2010, you know. I didn't remember my husband. I was like, who is this strange man that keeps coming to visit me every day? I remembered my son. But yeah, it's insane. And my memory before was absolutely terrible. It's not much better now, but it was really bad. You would tell me something and like 5 minutes later I'd be like, oh, hey, so blah, blah, blah. And they're like, you just talked about that right now. So yeah, I have definitely come very far. But yeah, I mean, it was my son, you know, that's my life, and I had to fight for him. And yeah, so it was quite the experience. Yeah.
I mean, how would you say your everyday life has changed, besides having your son now, but how has your everyday life changed? Your routine, your job, how has that all changed?
Well, I mean, I also had to learn how to drive, you know, because yeah. And so, I don't know. It's crazy now. My life is completely different now, absolutely. I struggle, but I'm always tired, always exhausted. I chug cups of coffee like crazy. And then with the child who's now 4, it's even worse. But yeah, it's just, I mean, I'm always exhausted, but I gotta power through it, you know, because who else is gonna do it but me? And yeah, because I have no family either. My parents passed away when I was in high school, so I have no family at all. So it's just me by myself. Yeah, it's definitely, it's tiring. I'm always tired. Yeah.
Representative Thierry, you know, when you're listening to a story like this, like what goes through your mind as a legislator, as a mom?
You know, I think about when you said, one of the things I wanted to share with everyone is what we're hearing is like what Dr. Ortique mentioned. There are some factors that are just things that are extraneous that we can't do anything about. If someone is killed by someone else after 9 months after having a baby, or it's a domestic dispute, then that's not something necessarily that we can start with at the medical level unless we're aware of it going on, and those are questions we can maybe ask the mom. If they die of an overdose, perhaps that's, again, something we can be looking at in terms of the psychological factors or mental health issues that may be going on. But for specific medical issues that are going on, what I think about, and this is what we did find, is that once again, you were released early when perhaps she should have still been in the hospital. And fortunately, you know, you got back in time before you passed away from having that stroke. Yeah. We have seen so many other read stories and anecdotes, and we hear about this nationally now, for example, with women of color. What we're finding, and you all, I have to talk about this here today because it's not, I wouldn't be doing my job if I didn't. What we're finding is that the implicit bias in even recognizing and treating and respecting pain from Black patients is not happening at the same level as with other patients. So, well, look at the experience that you had. Now imagine if you were a Black mother that came in. Now hopefully they would have treated you the same, but there was a 2016 study that was reported in the New York Times and the Washington Post recently in the past few months. They just put all the findings out. That is really shocking, you all. It literally said that there are medical students right now, as a University of Virginia researcher, that interviewed medical students and some physicians and found that they still believe medical myths regarding Black pain and white pain or Black medical conditions. For example, they asked the question, did you believe that Black people's skin is thicker than white skin? The answer was yes, that's false. They, just so you know, that's not true. They asked questions, do you believe that a Black mother or Black person's blood, should I say a Black person's blood coagulates thicker than a white person's blood? They thought that it did. They thought that the nerve sensors, the pain nerve sensors for Black people were higher, so they felt that Black people could endure pain at a higher level. So these are things that we're finding out now. So it's not about finger pointing. These are just stereotypes that educated people believe. And so this is why we're talking about we need implicit bias training. And so what it comes down to is if you're a working class mom, or let's say you're a poor mom that doesn't have access to what we've been talking about, Medicaid, because we don't have Medicaid expansion, or they don't have quality access, then you're not necessarily going to be treated because you don't have the access because you're poor. And then let's say you're Serena Williams, who's rich and famous, but everyone, they ignored her pain complaints. So she almost died and was having a pulmonary embolism because they wouldn't run the test because no one believed that she was having the problems that she was diagnosing herself and saying, look, I know what's happening to me. So this is why it's so important to talk about this. And I thought when we, I'm so glad that you all looked at the socioeconomic factors and the education factors. I thought that the findings were going to reveal the opposite. I thought it was going to say that most of the women that were passing away from childbirth were poor, and they didn't have a college education, and they didn't have access to health care for Black women. I did not know that if you were me, you're still more likely, I have a law degree, I have private insurance, that I'm still more likely to die in childbirth than a woman who's maybe the same age as I am, but doesn't have access to health care, doesn't have a college education, and is on Medicaid. So I think the implicit biases are a really, really big issue that we've got to deal with. And Marissa, that is something that we are addressing, like I said, at a local level. That conversation is starting to grow nationally. And Dr. Ortique probably can opine more about this. The stress from racism and discrimination is obviously, can be a cause of hypertension for other groups. And so we've got to talk about this. I call it the elephant in the room, but that's a big deal if you're going into an emergency care situation and your physician is not able to diagnose and treat you with the same sense of urgency that that physician would a group of another race or care. And I'm so grateful that you're here to share your story and that you survived this. But once again, you were released early, and we're hearing lots of stories of other people of color that didn't even make it to this point.
Yeah, I would love to add on.
Get on in there. Yeah.
That's the issue of race is often seen as a divider, and the reality is that's why we have the issue of race in our country. It is a social construct. The Genome Project has shown that under the skin we're essentially the same, and yet we consistently see people who would benefit from things like Medicaid expansion vote against it because they've been led to believe that if you, because racism has been kept alive, and in some people's minds, voting for Medicaid expansion is something like bringing government in and supporting poor blacks, when the reality is, just like the birth statistics in this state, only 11% of the births are from Black women, and yet 50 to 55%, as I said, are paid for by Medicaid. And so clearly more women than just Black women are benefiting or would benefit from that. The concern about race and health inequities has been around for a long time. I'm excited to hear about the newer studies that are coming out, but these studies have been being done since the 60s. There are reports of the inequities and the impact of just being Black in this country. There are theories. Mine is that cortisol levels are higher, and for the non-medical, cortisol is a hormone that causes blood sugar to go up. It goes up, it's the thing that goes up when you're under attack, okay? So it was a protector for us when we were prey animals, but now humans are no longer the prey, we are the predators. But people who experience stress on an ongoing basis have higher cortisol levels. So they may have more hypertension, they may have more diabetes. And that's why it's been shown that actually African American women who have higher degrees, so if you have your JD or your PhD, you actually have a higher risk for having health inequities than a woman who has maybe just a high school diploma. And the theory is that you've succeeded in a world that doesn't look like you. And so daily you have to deal with certain other pressures that someone who maybe has less education may not be experiencing, because the world that you live in probably looks very much different from who you are. So, but we don't want to focus only on that, because the issue right now, and my reality is, we're probably not going to be able to change racism, but we can change some things. Doing implicit bias training, because there's a difference between institutional racism, which is the things that keep you in from getting loans if you're a person of color. So that's not just African Americans, but Latinas as well. From being able to buy a home in a neighborhood that is close to a hospital that has providing good care. Those kind of things are big problems, big societal problems that we need to look at. But we could expand Medicaid. Bottom line is, if you get medical care, which women during pregnancy often get great care, but then they lose insurance when they're no longer pregnant. And so they're pregnant, they get care, they're not pregnant, they don't get care. Before the pregnancy, they're not getting care. So they come to the doctor with blood pressures that are really high or blood sugars that are out of control. If they had access to medical care across the continuum of their reproductive life, we would have healthier pregnancies, healthier mothers, healthier babies, less cost on society. It's simple math. We spend more on taking care of high-risk patients. I'm glad that you are here. I was so excited to meet Sable, but I can promise you that the care that you required because of having a stroke was immense, the cost of it. And for anyone who is insured with public insurance, that means the community, your tax dollars, pay for that care. So one way or another, we're going to pay for it. So why not make it such that women of all ages have access? And if we can't go that far, at least have access for the 12 months after pregnancy, so that you're healthier going into the next pregnancy, so that you're healthier while you're taking care of your children. If we did just that, we would see a huge difference, a huge decrease, I think, in the severe illnesses and death that we see.
I wanted to ask something. You know, I wanted to not leave that point on the table that you mentioned about the preventable deaths and the number. We said 89. Well, I think there may be, 89 of us in this room, or a little bit more or less. 80. So if there, can you imagine 89 of us in this room dying right now from something that was completely preventable? I mean, that would be shocking, a catastrophe. It would be making our news everywhere that 89 people sitting in this room died. That's how I see it for these mothers, from something that's preventable. And so that's what I'm hoping that we can drill down on. If it's preventable, like you said, one is too much, but that's why that number is high, and that is the message, and that is why I speak to my colleagues. And that is something, and when you explain it to my colleagues that way, they do get it. You know, they may not understand all of the nuances because they haven't, I mean, they have the capability to understand, but they haven't been briefed on that. But if you sit there in a room, if there were 89 legislators in a room and we all died suddenly from something that was completely preventable, you know, that's what we're looking at. And so if it's preventable, that number is way too high, one is too high. And so I'm hoping that more information will come out. If it's the ones that are preventable, if it's from hemorrhaging and it wasn't diagnosed quickly, or there wasn't a uniform protocol being followed from one doctor. Her doctor, I imagine, took one assessment when you were leaving and made one decision to let you go, and perhaps there was another physician that would have done something differently. I believe, if you can explain to us, is that what the bundling means when they say the ACOG recommendations, that when there's a certain condition presenting itself, that there would be an automatic certain response, a uniform response in Texas or nationally?
So you mentioned the bundles. So briefly, the Alliance for Innovation in Maternal Health, or AIM, born out of the issue of the rising maternal mortality rate in this country, led by, it's a group of about 17 different national stakeholder groups, has come up with safety bundles. We can look at California. California looks a lot like Texas. It's a border state. It's a very diverse state. It's a huge state in terms of geographic differences, so very, very, very similar to Texas. And in fact, as I was speaking before, back in, about 2006, 2007, California had a higher maternal mortality rate than Texas. And when they saw their rate go up, they reacted immediately. They formed one of these task force to look at the deaths and figure out, well, why are these women dying? They identified that hemorrhage and hypertension were the top causes, and they came up with solutions, recommendations, protocols, if you will, guidelines that were instituted in their hospitals across the state. And they saw their death rate, maternal death rate, start coming down, so that now their maternal mortality rate is lower than the U.S. It is actually the lowest of any state in the U.S. And so they have still the same demographics, and yet have been able to see a difference. And so nationally, these guidelines exist, and I'm happy to report that in Texas in June of this year, there was a kickoff for what we're calling Texas AIM, and we're addressing hemorrhage as the first bundle that's being introduced into hospitals. And so what that means is that, yes, when someone comes in who has certain risk factors, you'll be prepared and anticipate that she may have bleeding. You'll have the right tools. You'll have her delivering at the right hospital. There are people who are going to be high risk. There's nothing you can do about it. Well, then they should deliver at a hospital that's prepared to deal with that level of risk. If you are ever pregnant again, you should probably deliver at one of what we call a level 3 at least hospital. There are 4 levels. But the important piece of it is that there are protocols that can be instituted. Right now we have the newest one that's being introduced is on substance use disorder, and it's actually being piloted here in Texas because that is a critical problem and one of the top causes of maternal death. But there's a hypertension bundle, there's a bundle with regards to stroke and cerebral vascular events, and so there are tools that are available. And I'm happy to say that 80% of the hospitals in the state that do have maternity services have signed on to participate in this initiative. And so from that piece, we're really excited. But that's going to probably impact those women who die during the first 7 to 10 days after delivery, things that are happening in the hospital. We've got to look at community level factors. We have to look at societal level factors, and we do have to look at individual level factors, because we hold focus groups, and what we hear is that often the women are not being heard. They're not being listened to. They felt, if you talk to women who have near-death experiences, to a letter, they say they knew something was wrong. When you talk to families of those who died, to a letter, they say she said something was wrong. And so we have to do a better job as physicians. We have to do a better job of listening. Family members, we have to do a better job of listening. Friends, when someone tells you that, you know, they feel really, really, really down after delivering a baby, you have to say something back. You have to ask, you know, have you talked to your doctor about that? You got a bad headache and you just had a baby? Have you told somebody? Do you think you need to go in? And so it's going to take all of us to impact change on this.
Q&A is starting in just a few minutes after this question. The mic is in my friend's hand over there, so start thinking about your questions. We just had a really great conversation around implicit bias, racism, and the importance of women being able to recognize what's wrong if they feel something is wrong. And yet, you know, even in this same discussion, we're basically, all three of you somehow said that the women, they may not have felt listened to. So keeping all of that in mind, you know, how do we help empower women of all races to advocate for themselves in their doctor's office? I mean, what does that look like? How do we, as a community, as family members, how do we encourage them to not let a doctor tell them no if they feel something's wrong? So if you start with Sable.
Well, I mean, in my situation, I told the doctor that I had a headache and my blood pressure was high, so the signs were there. They just didn't listen, you know, which is very unfortunate because the whole thing could have been prevented, you know. Yeah, I don't know what to do about it because it's, yeah, I don't know, but if somebody has an answer for that, please tell me because I want to know.
I'm not so sure. I think there's two phases to it. I think as Dr. Ortique was mentioning, before you have the baby, before the women are having the babies, I'm not so sure that they're just suffering silently. You know, they are conveying that something is going on. We're talking about a larger, more pervasive issue in society. Like you said, it's not just women of color, it's all women. This is something that we talk about all the time. Do people believe women as a whole? You know, are we still viewed as when a woman is saying something with a higher pitched voice or with a sense of urgency or with speaking with a lot of passion, is she deemed hysterical or paranoid? I know this is a different topic and you all talked about this, but there were conversations going around just the Kavanaugh hearings the other day and saying, imagine if Dr. Ford had presented herself as angry and hostile and was screaming and threatening and going on and on and on, would she have been deemed at all credible? She would have been called nuts and probably crazy. So that's something, if you can start from that level and see how it happens. And then I'll go back to my Serena Williams example. I know she had that recent argument with the referee at the US Open, I believe it was. And it was wildly reported that she was just hysterical, the mother of all meltdowns. And then they showed other instances where men had literally cursed them out and thrown things at the actual referee and all of that. So once again, how do we view women in our society? You know, do women have to be considered docile and calm and quiet to be listened to and to be heard and to be respected? So what we really want to do, I believe all of us, is to have respectful maternal care, which means on a whole level, listening to the patient from beginning to end. And yes, we need to start encouraging women if we are being a little too apologetic or a little too polite because we don't want to annoy someone. I know I met with a group of African American women in Houston. We did a town hall at the YWCA, and there was a huge consensus that they were afraid. Now, this is one part where it was the individual's responsibility. They were afraid to repeat what was really bothering them to the doctor because in a way, if they felt like the doctor was ignoring them, because they didn't want to be considered angry, because they thought there'd be some kind of, retaliation for that they wouldn't get treatment at all. So that is something that we have to start having more conversations about. And so that goes on. But then after women have the baby, the second part, I do believe then women are more likely to suffer silently and not call back because the focus of care shifts to their child. And so the self-care tends to go away because the maternal instinct kicks in and their focus is on taking care of their child. I would love to see, as part of, as I was saying, that 3, 6, 9, 12, and 15 and after, and ongoing practice, the physicians talking to the moms about that. I shared with you at another panel that my doctor never saw me again. No one ever called me after I had my daughter and I had a near-death experience. No one checked on me. They never called to ask me to come back to see how I was feeling. But if those conversations are had before you even deliver, you know, in 3 months we're going to talk about this. And so that's what we're seeing right now in Houston, Harris County. That's part of our best practices that the clinics are using. They're assigning care managers that will follow up with the moms so that their concerns are heard and that they feel comfortable telling their care manager. And so all of this is going to take, there's so many moving parts. You know, we need the funding for that. The patients have to be educated. But I go back to saying on a societal level as a whole, do we believe women? Do we trust women? Do we respect women when they are conveying their thoughts and their feelings on any issue? You know, what is the standard? Are women having to meet a higher threshold to be believed and respected? You know, I don't know what it's like to be a man and to go in and to tell your doctor you're not feeling well, or your arm is hurting, or you've got a headache. And I don't know if there's an immediate sense of urgency from that doctor. Oh, sir, you may be having a heart attack. Let me get you right in right away, versus, you know, with the women, well, you know, let's sit down and lie down for a little while, or, you know, calm down. So I have no problem saying that I know that that's an issue, because we see it in all areas of our society. And so as we change the conversation and create awareness, I believe all of these things will tend to lessen.
Yeah, I totally agree. I've had several conversations across this weekend around the fact that actually it seems that sexism is worse than racism in this country, which is why when you combine the two, you have such poor outcomes for African American women. But having said that, as a physician, I of course, my heart feels like I have to say most doctors do care. Most doctors have a caring heart. Most doctors want their patients to do well. Most doctors are crushed when there's a bad outcome. We see, we're called the extra victim in these things. And so this is not, when I make statements like women don't feel heard, or focus groups show that women aren't listened to, I'm not castigating all physicians, but what I do know is that we don't have enough physicians. We need mid-level providers as well, that not every pregnant woman needs to see a doctor. Many could be cared for by midwives. We have a shortage, particularly in rural areas and in urban areas. There's the difficulty of access, but due to often finances. But in rural areas, it's truly that there are not enough providers, there are not enough facilities, and so we have to build capacity, and that's going to take a lot of time and energy. But I think that some of the steps that the representative just described, we call healthcare navigators, because the healthcare system is extremely complex. I moved to Houston from Austin. When I was here in Austin, I was in a multi-specialty group, so I could see any specialty. As a patient, I could go easily. In Houston, it's incredibly difficult. We're all siloed, and I know the medical system. I've actually been practicing OB-GYN in Texas since 1995, and I've been a physician since 1986. So I know the medical system, and if I have problems getting through it, I guarantee you that everybody else does too. And for women who have other pressing needs, they have kids to feed, they have homes to take care of, they are working, they are doing everything. to have a navigator would be really helpful. And so getting those navigators paid for. Navigators are just people who will go with you to your appointment, make sure you get there, listen, because as soon as a doctor says something like cancer or your baby has a problem, you have X, Y, or Z, your brain changes. You may not hear everything else. And so taking someone with you or having a navigator to help you get through and make sure that you're actually hearing what's being said. Because often we're saying things, but we're either saying them in a way that you don't understand, or we're saying them so quickly because we have to get to the next person that it's not received. And then sometimes it is just you're young, you're healthy, you're supposed to be able to have a baby, right? And we think that as an individual, women believe that. You're brought up to think that that's just normal, that's what you're supposed to do. And people have been having babies forever, but I always remind people that, well, back in the 1800s, women lived in fear of being pregnant because they knew they might die. It was in 2006 that we hit the lowest, and now we're back up into the levels that we were in the early 1900s. And so we have to listen, we have to advocate, we have to provide access, and we can do better.
We're going to start Q&A. So if you rate, okay, wow, already a few. I saw this hand over here in the blue. We'll try to just keep hopping around.
Hi, my name is Blaire Cushing, and I'm actually a family physician. I did my medical school training in Texas and recently completed my residency in California, so I've actually gotten to see both sides of things. And in California, we talk about them being sort of ahead of the curve, and they've done a lot of things, in particular in the hospital, to try and prevent postpartum hemorrhage and hospital bundles, and following the algorithms and all that is pretty fantastic anywhere I've been. But what I worry about, and what I know is also going to continue to be a problem both in California and Texas, is the true postpartum care, meaning once we let you go from the hospital. This is what I really worry about, and I think a lot of this actually may have more to do with some of our systems, such as Medicaid and private insurers. And what do you think that we can do about changing the way that women are able to get that follow-up care? Like you mentioned, you never even really saw a physician later. So what are the kinds of things we can do to make those changes?
I would say the first thing is this. Number one, so in our state, you lose the Medicaid that you could get because you were pregnant 60 days after you're not pregnant anymore. And we know that you need at least a year if you were high risk, okay? So if you had hypertension during pregnancy, you need at least a year of care. But to get that care, you have to have insurance. And so by expanding coverage, if we can't have coverage for everybody, and I'm sorry, I think that healthcare is a right. It should be. It's not in this country, but it should be a right. Everyone should have access to care. But okay, we can't get there. We could at least cover for 12 months after delivery. I think we could do a better job of educating women about the importance of postpartum care, because many times if you don't know that you need to come back in, why would you go back? So educating women, educating the community, providing insurance for that period of time after delivery, I think would go a long way to improving our outcomes. I think you had.
Yeah.
She said it all?
Yeah,
she said it all.
And yeah, Texas, we know we're still, unfortunately number one in being the uninsured capital of, of the nation. So I echo what Dr. Ortique said, but also I know in the short term, we can do things on a local level. For example, New York recently put forth an initiative, their mayor, I think there's $11 million that he's awarded for community initiative programs and grants, which will actually directly impact these kinds of communities where they are providing postpartum care for mothers. It's an entire system where they assign what we're talking about, the care managers and all of that. I'm going to be writing a letter to my mayor in Houston asking for the same when our budget is established. And then if this Maternal Care Act passes in Congress that Senator Harris has put forth, there's the $150 million in appropriations they're asking for that. And they're giving the grants to, if it were to pass, 10 states would be eligible to draw down funds from these grants, and the states that have the highest racial disparities and the highest morbidities and mortalities would be eligible. So that's us. You know, we're going to be up there, even with the reduced numbers, we're going to be up there in the top 10. So if we can get more funding to address these issues over time, it will look differently.
Yes, you purple looking shirt.
Hi, I'm Raj. I'm a student at Rice University along with some friends, and we're leading a service learning trip this upcoming spring break to investigate maternal mortality in Texas. And I wrote down my question because it's kind of long. But Representative Thierry spoke about implicit biases and the inability of physicians to sometimes truly empathize and understand the conditions of a mother going through delivery, and how this could lead to misassessments and negative medical outcomes. And I was wondering if there's any studies that look at how physicians from different personal backgrounds may have discrepancies in outcome. For example, physicians that have gone through labor and delivery themselves, do they treat patients better than physicians that haven't?
I'm going to say that I'm not aware of any specifically speaking to having given birth and that, because number one, that would eliminate more than 50% of the physicians who care for women, because more than 50% are male. So I'm not aware of that as a study, but I am aware of numerous studies that look at they look at race, and they look at income levels with regards to treatment of patients and some of the differences in that.
I read somewhere, and this wasn't solely having to do with maternal care, Raj, but that even women need implicit bias training when treating and dealing with other women, because there are times that it works in the reverse, that sometimes even a woman will be harder sometimes on a woman because she may be thinking, well, I wouldn't be responding this way, or I didn't do this when I went through it, excuse me. And so, and that is why I advocated, and that's why I said it's not a blame game. Right. It's not a finger pointing game. You know, this is just the reality of the world that we live in, and that is why I'm calling and asking for the bias training across the board. That would include African American physicians and African American women.
Everyone has biases. So right. This is the thing. Bias just means you either favor or disfavor something based on a belief system. So I like football. I don't like basketball. My bias is towards football. It's negative bias that we are thinking of, but all of us have biases, and so they're out of Harvard. There's these tests. They're called implicit bias tests, and when you take them, you'll find that everyone has them. TMA, Texas Medical Association, is looking at doing some of that focus group and implicit bias testing among our physicians, because sometimes you find things that you will be surprised by. It's very easy to assume that because a person is black, say, that they'll take better care of black patients. That may be, when you look macro, that may be true. So at large numbers, it may be true. It has been shown that African Americans may prefer to be treated by African American physicians, but there's only 1% of the physicians in this country are African American and 11% of the population. So yeah, we can't all see a black doctor. And Black doctors, likewise, I practice in the medical center. My population, I have Medicaid as a large percentage of my practice, but they do not look like me necessarily. In fact, I know that I do not have majority African American patients, so I need to learn what my biases are as it pertains to taking care of other women. And so everyone benefits from recognizing that we all have biases. We can't help it. We grew up in this country. We all have. Once you recognize them, though, then you can address them. You can say, well, I think people with red hair aren't as polite as people with brown hair, so when the redhead comes in, I'm going to be on my toes not to react to her in that way, okay? So that's what implicit bias training is. It's not to say that one person is better than the other. It's recognize that you have it and then figure out how you work with it, because that will improve the individual and improve the care that they give.